Rayshna, where Rayshna? So
Good morning to everyone present here. I'll be presenting on behalf of Medicine 3 about an interesting case that we came across in our ward. My presentation is titled When Little Red Riding Hood Cried Wolf. So this is Mrs. V, a 64-year-old lady who presented with history of generalized weakness and fatigue since 6 months, decreased oral intake for 3 days, and sudden onset giddiness with one episode of fall last night, that is the day before she came to ED at 10 p.m. At 10 p.m. last night, she suddenly experienced a sensation of giddiness upon getting up from her bed. There was no history of any seizure or loss of consciousness, no history of any pre-syncopal symptoms such as diaphoresis, palpitations, or visual blackout. Following the fall, she felt weak and fatigued with mild drowsiness noted. Personal history wise, she's a known diabetic for 4 years on tab metformin 250 mg BD, and her son reports loss of weight and appetite. On examination, patient was conscious, GCS with 15 by 15, but she was mildly drowsy. How she obeyed commands. Pulse was 88 beats per minute, blood pressure of 100 by 60, respiratory rate of 22 breaths per minute, SpO2 of 98%, temperature of 98 degree Fahrenheit, and GRBs of 220. She was dehydrated at the time of presentation. There was no pylorictus, cyanosis, clubbing, lymphadenopathy, or pedal edema. JVP was not elevated. We had noted 2 hematomas on the right temporoparietal region with surrounding erythema and also on the posterior aspect of her scalp. It was lacerated, but by the time she came to the ward, she had stopped bleeding. Systemic examination, there was respiratory system, cardiovascular examination, and abdomen examination was normal. CNS examination, higher mental functions, MMSE, we could not assess as she was drowsy. GCS was 15 by 15. She was oriented to time, place, and person. Cranial nerves, second cranial nerve, right pupils, right was 3 millimeter and sluggish, left was 2 mm and reactive. She also had left eye mild ptosis and meiosis that was noted. 5th, 7th, 8th, 9th, 10th, 11th, 12th nerve was normal. Bulk was reduced. Generalized reduction in bulk was noted in all 4 limbs. Sensory system examination was normal. Other reflexes, deep tendon reflexes were 1 plus, both bilateral upper and lower limbs. Signs of cerebellar dysfunction, there was no nystagmus. We were unable to assess the other functions. Meningeal signs was absent. Spine and skull was normal. So this is a syndrome complex of loss of weight, loss of appetite, and generalized weakness, which is spanning over a period of 6 months, along with new onset giddiness. So we had considered metabolic causes where she would have had deranged electrolytes, either sodium being low, hypernatremia, hypocalcemia, or even hypomagnesemia. We had also considered endocrine causes, which might involve the thyroid gland, hypocortisolism, hypoglycemia, or hyperglycemia, with an underlying malignancy. So, along with the examination finding of unilateral Horner syndrome on the left side, where she had mild ptosis, partial ptosis, along with meiosis, clinical localization was to the first, second, or third order of the sympathetic chain. So additional history wise, she previously had history of prolonged headache for which MRI scan done at the time showed a similar finding where she had imaging appearances on MRI for an aneurysm, which is probably from the supraclinoid internal carotid artery. We had also done laboratory investigations pertaining to the differentials that we had considered, where the significant findings were that of a hyponatremia, where she had a sodium of 125 and her 8 cortisol was 1.5. We had also checked her TSH levels, which was normal, 1.306. T4 FTC was 8.4 and 0.96, which is normal. Glucose was 220. So with the background history of headache, the examination findings of unilateral Horner syndrome and hypocortisolism on lab findings, we had localized it to the suprasellar area. So why this was because on examination we could not find any other neurological involvement. So we had considered the third order neuron to be involved, where the cavernous sinus or the anterior pituitary gland itself was affected. We had gone ahead with an MRI brain with contrast, which showed a thrombosed intracranial aneurysm with a peripheral rim of calcification overlying the pituitary fossa, causing compression of the pituitary gland itself with no evidence of bleed or mass effect. And she had subdural hematomas pertaining to a fall as well. So the final diagnosis that we had arrived at was a central hypocortisolism secondary to an intracranial aneurysm causing pituitary compression. So I'd like to talk a little bit about the case that we had come across and reports pertaining to the same. The pituitary gland is located in the suprasellar fossa, and it is surrounded by many vital structures where involvement of any of them can affect the pituitary gland itself, including the ICA, the cavernous sinus, sphenoid sinus, and there are a few case reports that they have noted where for hypopituitarism itself is caused by intracellular aneurysms. There have been around 0.17% of cases. And from 1960 all the way to 2022, there have been around many cases where they have explained about these patients who present with hypocortisolism, where they come in drowsy. And the similar findings that I had noticed among all of them was that they were elderly with a low sensorium, with generalized malaise, along with hyponatremia at the time of presentation and hypotension as well. So in our patient, she was started on injection hydrocortisone followed by steroid replacement therapy, where she received 502.5 mg of prednisolone, following which her sensorium improved. And we had also worked up for the other hormones as well, which is involved in the pituitary axis, mainly the thyroid. Given her age, we did not send FSH and LH. And she is to review neurosurgery to plan on coiling of the aneurysm. Learning points for this case were that of localization of those who present with Horner syndrome, syndromic presentation of patients with hypopituitarism, and prevalence and importance of considering it as a differential in patients who present to ED.
Thank you, Rayshna. Interesting but an unusual patient, I would say. So before, one is the anatomical localization, which is important because she obviously had focal levels. When she came, and I'm so sorry, what was her blood pressure and her electrolytes? No, just to say, because she came in because she fell down.
She came in, yes, ma'am. Her blood pressure was 100 by 60, ma'am. And her electrolyte sodium was 125, potassium 3.9, and bicarb of 18 or 19.
So we are just looking at, because the patient came in because she fell down and hit her head at the end of the day. And why did she fall down may not exactly link directly to the final consequences of. Can anyone tell us about, remember, or you can tell us, Rayshna, you talked about which order, no, for the Horner syndrome. How do you divide the first or second order and for a Horner syndrome? For a
Horner syndrome, central, second and third order of neurons, while the central is anywhere which is intracranial, from the hypothalamus all the way to the spine. And the second order would be anywhere transthoracic, where you could get patients who present with an apical lung malignancy. They can present with Horner's. And third order is anything involved the carotid artery, pertaining to the around the carotid artery, the plexus.
So we've kind of localized it, but it's like a specific set going from central to about, say, C8 to T2, then pre-ganglionic and then post-ganglionic. Okay. So very interesting case. So the patient is being referred to neurosurgery, yes, is it? Okay, sure. Any questions from the people who are helping Rayshna treat the patient versus from the... I think the other points that I had noted just to give as feedback was, anatomical localization, which you did give us. The other points would be, I think when you all are presenting lab values, because you all at various years of your training, it's good to point out what is a normal range. I know that some of you all know it by heart, but I think because you're at various ranges of your thing, when you put in your, I mean, I'll know what is abnormal. Yes, you'll know what is abnormal because it's your patient. Maybe it's good to also put the range there so that people can understand what is relevant. But obviously she came with something and we found something else. Not all of medicine is like that, but in this particular patient, she had an unusual finding which we needed investigations for. Any question, any comments from the treating team versus from the audience? Okay, thank you so much, Rayshna. We'll go to the next presentation from Medicine 4. Yellow, not mellow. Dr. Bless, please.